Assalamualaikum and good morning. I'm Dr. Rabiatul Adawiyah binti Sufyan, FMS Bedeti from KK Salah Sepang. I would like to present on influenza-like illness. I really hope that you will enjoy and learn something from my presentation. These are the outline for my talk, which include influenza-like illness, management of ill in pediatric patients, adult and pregnant lady. Lastly, I will talk about prevention for influenza. Influenza affect 5 to 15% of the population annually. The cases peaks in May to July and November to January. However, influenza can cause severe illness or death, particularly among high-risk groups such as the very young, the elderly, and pregnant women. Infected persons are contagious 1 day before symptoms and up to 5 to 7 days after onset. They are no longer contagious after a febrile for 24 hours without fever medication. However, asymptomatic influenza occurs in 30% of cases and they are infectious and still transmit the infection. There are four different types of influenza viruses. Influenza A and B viruses circulate and cause seasonal epidemics of disease. Influenza A viruses are further classified into H1N1 and H3N2. Only influenza type A viruses are known to have caused pandemic. Influenza B viruses belong to either B Yamagata or B Victoria. Influenza C viruses is detected less frequently and usually cause mild infection. Influenza D viruses primarily affect cattle and are not known to infect or cause illness in people. Influenza virus spread primarily via person-to-person respiratory transmission, which occurs via close-range contact that is within approximately 6 feet, either through large droplets or aerosol. Influenza virus can also be transmitted at longer distances through the airborne route. This happens by inhalation of small particle aerosol that remain suspended in the air over time. Incubation period is ranged between 1 to 4 days. Influenza typically starts with fever, sore throat, headache, and myalgia, and extreme fatigue followed by rhinorrhea and dry cough. Rash has been described in influenza B. In the elderly, fever may be absent, and the other presenting signs may include anorexia, lassitude, or confusion. Children also may present with vomiting and diarrhea. This table lists down the available method of diagnosing influenza. Rapid diagnostic tests are used in clinical setting, but they have lower sensitivity compared to RT-PCR method. There are several methods of specimen collections, and we commonly use nasal swab. The risk for serious complications from influenza infection is increased in persons at both extreme of ages as well as in those with certain underlying conditions. High-risk patients includes children less than 5 years old, adults more than 65 years of age, especially those with other chronic diseases, pregnant women, especially at second and third trimester, patients with chronic respiratory conditions such as bronchial asthma, COPD, OSA, chronic cardiac disease, chronic illnesses including diabetes, CKD, cancer, patient on chemotherapy and long-term steroid, and also patient with BMI more than 40. The most common serious complications of influenza include exacerbation of COPD, asthma, and congestive heart failure, as well as development of bacterial pneumonia. Bacterial pneumonia commonly caused by Streptococcus pneumonia, Staphylococcus aureus, or Haemophilus influenza. How do we define influenza-like illness? It defined as a history of high fever with temperature more than 30 degrees and cough within the last 10 days. Basically, if a patient is triaged with suspected ill, his patient will be directed to a separate waiting area, fever zone to receive further assessment. Staff handling ill cases need to use proper PPEs, which include N95 masks, gloves, and apron. What is the current treatment for influenza in Italy? Currently, we have oseltamivir, or famously known as the flu. Oseltamivir shortened the duration of influenza symptoms by approximately 1 day and also reduced the duration of viral shedding. Clinical benefits associated with oseltamivir treatment include reduced risk of pneumonia, one of the most commonly frequently reported cause of death in infected people, and a reduced need for hospitalization. Later initiation of treatment may also be beneficial. This decision should be made on a case-by-case basis. If the symptoms are improving beyond their first 48 hours, treatment may not be necessary. Now we move on to management of ill in pediatric population. We would like to emphasize the importance of assessing patients for any symptoms and signs of moderate to severe illness, as we need to refer these cases to hospital. Moderate to severe symptoms in children include severe respiratory distress with lower chest volume growing, sternal recession, grunting or noisy breathing, increased respiratory rate which is measured over at least 30 seconds, SpO2 less than 95%, respiratory exhaustion or apneic episode, and evidence of severe clinical dehydration or clinical shock with sternal CRT more than 2 seconds, reduced skin turgor, sunken eyes or fontanelle, and lastly, altered conscious level with strikingly agitation or irritability, seizures or floppy influence. Next, if the child didn't have any signs of moderate to severe disease, we need to assess whether this patient has any comorbid and risk factor. If yes, we need to rule out other differential diagnoses such as COVID-19 and dengue. Then we decide whether there is any indication for acetaminophen. Comorbidities that we need to consider in children include cardiac disease, chronic respiratory disease such as asthma, bronchopulmonary dysplasia, other chronic diseases such as diabetes mellitus, chronic metabolic diseases, chronic renal failure, hemoglobinopathy. Chronic neurological disorder include muscular dystrophy, impaired immunity include HIV infection, childhood malignancy, or immunotherapeutic therapy. Children less than 6 months old, malnourished, or obesity. In children, oseltamivir dose is depending on their age and weight, and this medication is given for 5 days. So once we decide that this patient for outpatient therapy, we need to let the parents know on how to assess this child at home. So they need to seek medical attention if the child shows any of these signs or symptoms, which include lethargy or poor oral intake, change in mental status or behavior, signs of dehydration, increasing respiratory rate with fast breathing, thymesis, fit, or persistent fever. So first case discussion, 8 months old baby boy with no non-medical illness presented with fever, cough and reduced oral intake for 3 days. Water sign shows temperature of 38, SpO2 96, RR 52. Vehicle examination reveals sternal recession, mild dehydration. So what is our impression at this moment and what is the next management? So the impression is moderately, so we need to refer and admit this child. 6 years old girl with no case of bronchial asthma presented with fever, cough, and runny nose for 2 days. Currently on MDI fluticasone 1 puff all day, MDI salbutamol 2 puff PRN. Temperature was 38.5. RR 28, SpO2 98% on room air. Physical examination reveals clear lung, no sign of respiratory stress with good hydration. So what is our management at this stage? The diagnosis is easy with comorbid, so we need to treat this child with oseltamivir. Now we move on to adult with ELE. So for adult ELE, the management is pretty much similar to pediatric cases. We have to assess severity early on since these cases need admission. Moderate to severe symptoms include respiratory impairment with RR more than 24, inability to complete sentence, use of accessory muscle, SpO2 less than 95, reduced effort of breathing, altered conscious level, especially in the extreme of age, new confusion, agitation, and seizure. Evidence of clinical dehydration or clinical shock, with systolic BP less than 90, diastolic less than 80, CRT more than 2 seconds, and reduced skin turgor. Or other clinical concern with rapidly progressive disease or serious typical illness such as severe and persistent vomiting. If assessment indicated that we can treat this patient as an outpatient, it is important to assess for comorbidities and any presence of risk factors. These are indications for oseltamivir. It is also very important to rule out dengue and COVID-19 as the presentation is very similar to illness. We need to educate patients on home assessment tool and emphasize the need to seek medical assessment if any of the symptoms and signs present. Respiratory difficulties, lesions of breath, rapid breathing, or purple or blue discoloration of lips, coughing or blood sputum, persistent chest pain, persistent diarrhea or vomiting, fever persisting beyond 3 days or recurring after 3 days, abnormal behavior, confusion, convulsion, dizziness when standing, or reduced urine production. Case discussion for adult patient, 70 years old, known case of COPD, presented with fever, cough, and shortness of breath for 2 days, temperature 38.5, RR28, SpO2 93% under room air, physical examination reveals mild dehydration and supraclavicular recession. So what is our management at this stage? Our impression is exacerbation of COPD and we need to refer and admit discussion. Next case, 40 years old male, known case of diabetes type 2 and obesity, presented with fever and cough for 2 days, temperature 38.5, hour 18, SpO2 97% on room air, physical examination was normal. So what is our impression and management at this stage? Our impression is ED with comorbid and we need to treat this patient with oseltamivir. Now we move on to management of ELE in pregnant patients. For pregnant patients, we need to refer and admit any patient with moderate to severe illness and also with a typical presentation. Now, I would like to explain about the atypical presentation in pregnant patient. So it's important for us to look for any signs and symptoms of myocarditis, pericarditis, rhabdomyocytis, Torsay short syndrome, transverse myelitis, and Guillain-Barré syndrome. So all of these atypical presentation warrant admission to hospital. So let's say we decided that our patient have mild illness and need to be treated as an outpatient. We need to advise them on adequate home care, advise them to take paracetamol to control the fever, and also to complete course of oseltamivir. Because in pregnant, all pregnant patients are indicated for oseltamivir. And they need to look for any signs of respiratory distress, proper hand hygiene, and they need to postpone their antenatal visit if it's possible. And let's say if any of the symptoms not improve or worsening, they need admission to hospital. So a little bit on case discussion. 30 years old woman, G2 para 1 at 26 weeks, with known case of bronchial asthma, presented with fever, cough, and chest pain for 2 days. A vital sign showed a temperature 38.5, blood pressure 120 over 80, pulse 124, SpO2 95%. Physical examination showed normal hydration, however, reduced air entry at basis. So, uh, what is our impression at this point? The impression is G2 para 1 with moderate ELE to rule out myocarditis. So we need to refer this patient for admission. So next case, 34 years old lady, G3 para 2 at 20 degrees, with no non-medical illness, presented with fever, cough, and runny nose for 2 days. She also had contact with positive influenza case. Temperature 38, BP 11270, pulse 88, RR 18, SpO2 97. Physical examination was unremarkable with good hydration and no respiratory distress. So what is our impression and management at this case? Our impression is G3 power 2 in my early and we need to treat her with oseltamivir. So how do we manage a newborn whose mother has delay? As a rule of thumb, breastfeeding is not contraindicated. We may separate newborn from mother with delay. Mother need to continue express her breast milk, wear a mask and frequent hand washing. However, if it's not possible to separate them, mother should continue breastfeeding with new blouse, wear mask and frequent hand washing. Lastly, mother need to maintain good cough etiquette. Now we move on to home care advice for patients. So for home self-care, we advise them to stay at home. If fever, take paracetamol and recommended dose. Get adequate rest. Drink plenty of fluids such as water, sports drink, juice or soup. Be watchful for any emergency warning sign and also good ventilation in shared household area. Another aspect of home care is the infection control at home. Maintain good cough etiquette. Do not share personal tents or linen. Improve personal hygiene for all in the household. Frequent hand washing. Wear masks. Maintain separation and distance. Individuals with influenza should remain at home from work, school, and other public places until at least 24 hours after resolution of fever, which means without the use of antibiotic and improvement in symptoms. Usually, they need to refrain from work or school for at least 7 days from onset. Now we move on to influenza prevention. Now, I would like to talk about non-pharmacological prevention, which include isolation, frequent hand washing, practice good cough etiquette, avoid touching your eyes, nose, or mouth, and also avoid close contact with sick people. Now, this timetable show the available influenza vaccine in Malaysia. So, for children aged 6 months to 8 years, they should be given 2 doses to optimize immune response. Target group for influenza vaccine include healthcare worker, person at high risk, person performing Umrah or Hajj, household contact with high risk condition, for example, caregiver for children less than 6 months old, and also there is a program Immunisasi Kebangsaan 2024, which was recently launched. But the vaccine is available for elderly aged 60 years and above with at least one comorbid such as diabetes, chronic respiratory condition, chronic heart disease, obesity, hypertension, dyslipidemia, and CKD. Adverse effects from influenza vaccine include soreness at the injection site, fever, myalgia, and headache. Contraindication to influenza vaccine include history of GBS occurring 6 weeks post-influenza vaccine, anaphylactic hypersensitivity to egg and egg antigen. Recombinant vaccine may be given to person with known egg allergies. A study by Roth et al. Showed influenza vaccine reduced the substantial burdens of influenza-associated illness, medical visits, hospitalization, and death in the United States during the 2017 to 2018 season. Finally, the take-home messages. Assessment and risk stratification is very important to decide on outpatient or inpatient management. Oseltamivir bed given in less than 40 hours. Last but not least, prevention is better than cure. These are the references for my presentation. Lastly, thank you very much for your attention and all the best for your tests.